Respected Secretary, Science Educational Trust, Dr. College of Pharmacy, respected teachers, faculty members, and dear students. Today we are celebrating second day on the 8th of National Seminar and National Pharmacy Week during this session. Every year, Pharmacy Week has been celebrated since 1935. All of you aware that in 1935, IPA has initiated in the name of United Province Pharmaceutical Association at Mumbai. Later on, it has been renamed as Indian Pharmaceutical Association. Indian Pharmaceutical Association, one of the apex body who is safeguarding the profession of pharmacy in our country. You know very well, pharmacy is a vital part of healthcare system. Pharmacy Council of India takes care the education regulation policy and it must take care regarding productions and necessary guidance in manufacturing of the pharmaceuticals. We are enlightened that with us, the most respected dignitary and the speaker, patil sir present with us to inspire you during the national seminar. I would like to invite to Dr. Anmol sir to our event national seminar on this occasion. I would like to give the brief introduction of Dr. Patil sir. He has been started his career since 2011 as a senior resident in PMMSC at Safdardjung Hospital, New Delhi. Later on, he has progressed in his profession from 2015 to 2019, worked as an assistant professor at Department of Pharmacology, PJMER, Chandigarh, one of the best institutions in India. Later on, he has been promoted and continued as a additional professor, Department of Pharmacology in PJ Chandigarh. Simultaneously, he has been promoted to the and what presently is the medical education in at PJ Chandigarh as a associate professor in Department of Pharmacology. He has been awarded with a different valuable awards, KBPO Fellowship Award and Early Career Research Award has been to his credit. He has been honored with the international conferences of cardiovascular research convergence and also in the organization team of International Society for Rational Pharmacotherapeutic Conferences and so on. I would like to invite Dr. Abrod, Associate Professor, Department of Pharmacology, Chandigarh, to join with us and to address our students and staff. Dr. Anmol Patil sir, welcome you sir to our institution, Entrepreneurship College of Pharmacy, and to this national seminar conducted on our institution. Welcome to
Thank you, everybody.
I would like to hand over to Dr. Patil sir to address. Sir, please join with us.
Hello. Hello.
Am I audible, sir?
Yes, sir. Audible, sir. Please.
Okay. Shall we begin, sir? Hello.
Yes, sir. Audible, sir.
Shall we start, sir?
Yes, sir. Please start, sir.
Thank you so much. Uh, I'll share my screen with you. You are able to see my screen.
Yes, sir.
Is the full screen moving properly? Slides. Hello.
Yes, sir. Yes, sir. It is visible, sir.
Okay. So very good afternoon, everyone. I can see there are esteemed faculties present on other side, along with the enthusiastic pharmacy students. So good afternoon. We are going to talk about drug information services today, and I have little differently framed the title. So drug information center or drug information services, they are giving you idea about evidence-based medicine on-call service. Okay, because the clinician calls us and we give them a best answer, evidence-based answer. Okay, and that is a brief overview I will give you. Everybody is fond of watching Netflix, right? Has anybody seen this series movie? Okay, I'll give you idea. This is a pharma company run by three professionals. Pharma company is marketing fentanyl, a fast release fentanyl. Fentanyl is a opioid painkiller. Okay, so they initially started for cancer pain. Okay, slowly off-labelly they shifted to oral ulcer pain also. Okay, just to make billions of dollars. Okay, ultimately they got hold by FDA. Okay, for the rampant usage of such a powerful opioid for pain killing action in oral ulcer patients. Okay, and the company been to the ashes. Okay, so it is a beautiful movie. You can watch. Okay, I recommend that. Another example is paroxetine. Heard of this drug, paroxetine? Paroxetine is an antidepressant drug that was initially indicated as the best choice drug for adolescent major depression based upon a single randomized control trial where it was compared with placebo, and with a marginal benefit it was drug of choice. So it remained drug of choice for almost 10 years. Later on, when FDA digged into data why so many children are committing suicide on this medication, they found out that the safety data was hidden and safety data was not presented in the RCT. Okay, so that was a hiding of the information done by the investigators. Okay, so the drug was stopped in adolescent depression because of suicide risk. Then everybody know what happens in COVID. Okay, I once again ask you, am I audible? Is the screen visible to you? Okay, so everybody saw in COVID what happened. In COVID, uh, UP government distributed free ivermectin like a kiosk ticket vending machine. Okay, anybody can get the ticket for bus, train, or anybody can get ivermectin. Okay, so it was freely available in the Lucknow. Was it a real world evidence? Was it really effective in COVID. That's how a treatment should happen via kiosk machine. What is your opinion? Okay, so here are some examples like RCTs can be faulty, the policy making decisions can be faulty. Okay, there can be a pharma company motive to create a sale out of it or create a money out of drug sale. Okay, so you have to be vigilant on the drug information, which is a right information, which is a wrong information. How can you educate the doctors nearby you? Okay, Danteshwari College must have a hospital nearby. Am I right, sir? Okay, so in that hospital, we can start a communication. Okay, that we can assess a good information or a literature pertaining to drug, and we can give you a best advice. Okay, so what clinical services a pharmacy department can cater for a doctor, for a clinician? Anybody? I would be happy if it is a reactive session or a participatory session. Okay. What pharmacy services are for patients, are for clinicians? You know pharmacovigilance, guys? You know pharmacovigilance? Adverse events related to drug? Yes or no? Hello? Okay. So similar to a drug adverse events notifications, you can have a opioid stewardship program. Opioid. Okay. There can be a rampant usage of painkillers. There can be more than necessary usage of painkillers. Okay. Patient may become addict. Patient can become drug addict for the opioid, for the painkiller. So here is a role of pharmacy professionals. Antimicrobial stewardship program. The antimicrobial resistance is rising. Okay, there has to be a judicious use of antimicrobials. High end usage directly can pose a big threat in the future. Okay, the infection can become out of hands and may lead to deaths. Okay, then therapeutic drug monitoring, you know, therapeutic drug monitoring, you can estimate drug level in epilepsy patient, in a transplant patient. Okay, and you can give them a best advice about dose titration. Okay, if a poisoning case occur because of drug or substance of abuse. Okay, substance of abuse, you know, guys. Okay, the cannabis related drugs, the opioid. Okay, they also need a proactive approach. Okay, they also need a scrutiny of prescriptions. Okay, so these all services should be running, ideally speaking, from your college, from your department to nearby hospital. It is mostly a reactive approach. What is in observation that a clinician generally calls, and then you give them a advice or the answer. Or you can create a newsletter. You can make a regular communication. Okay, in a printed format, in an email format, in a SMS format, in a WhatsApp format, or it can be a combined approach. It is up to you how you want to see your services. Okay, there are certain diseases which are not seen in the US or UK or the developed countries like snake bite, tuberculosis. Okay, we saw that snake bite cases were so high in the recent past. We saw that dengue malaria cases were so high in the recent past in the rainy season. So, who will provide evidence based information for the management of such cases? Because evidence is not generated in US or UK or other developed countries. We have to generate our evidence, no? Okay. So, region specific evidence has to be built by our own hands. Okay. It should be relevant to our patient population. It should be relevant to our doctors. It should be up to date and user friendly. So we began a drug information center. Everybody is able to appreciate the image. Hello, you are able to see this image? Okay. So it is a drug information center. We also call it as a evidence-based on-call service where we help clinician assist in research, okay, how a clinician should frame a clinical trial. We assist, we help them in designing clinical trials. We help them with their queries like a sustained release drug comparison with a fast release drug or a plain drug. How should be a trial, whether it is a crossover trial, whether it should be a parallel arm trial. Okay, if a drug has to be directly administered in CSF, okay, how much modification can be done? Okay, so we give them an idea what organ function to monitor in a dialysis patient, how vancomycin should be administered. Okay, can a vancomycin level guide a target therapeutic approach? Okay, so we also guide them. We do pharmacogenetic testing, okay, for warfarin, for azathioprine dosing. Okay, so genetic testing can also be helpful, right? So we also help them in interpretation of antimicrobial susceptibility report. We also help them in causality assessment, whether a drug should be stopped or whether the drug can be considered for dose decrease. Okay. We also provide counseling service, like a G6PD patient come to us, okay, which drugs should be avoided by G6PD patient, what drugs to be avoided by myasthenia patient, what drugs to be avoided by long QT syndrome patient. Okay, so we give them a information, we give them a education session. Okay, then poisoning management, we also guide them. So all these services you can also start catering to a nearby or affiliated hospital. Okay, we all know that we have a national health program with the name of pharmacovigilance. It is a national program, right? Countrywide program, pharmacovigilance. How simple ADR reporting grew to the level of a national health program. Okay, so can we begin our drug information services also to take up to a national health program? Yes, definitely. We have to start. Okay. So we began with our resident, duty resident. They were guided how to receive the queries over phone. We had a landline initially, then we switched to mobile on call, okay, service. A duty roster was kept for the resident. They received query. We digged up the literature in PubMed. Everybody is aware about PubMed. PubMed. Okay, so we try to synthesize our evidence. We did a facts checking in the textbooks. We had a consultation with seniors. We verified answer and we gave the reply to a clinician. That's how we began. Then when we started, we saw that many of the residents, they require dose guidance. Many of the new joinees in the hospital residents, they have a requirement for dose guidance. In a kidney failure patient, how to decrease the dose. In hepatic failure patients, how to decrease the dose. Okay, what possible drug interaction can happen. I can understand the slide may not be visible, but this is the initial communication I started with the doctors. Okay, in a written format also. Okay, this is a roster of my residents I started initially. Okay, then I started communicating with all the doctors in a printed format on my letterhead. I upgraded the services for patient counseling for G6PD deficiency, porphyria, mastocytosis, long QT syndrome, myasthenia gravis. Patients started coming to me, doctor, what drugs we should avoid. Okay, so we have a dedicated sessions for the patients where we guide them, where we educate the patients what drugs they should be avoiding in future. Okay, this is a Harvard newsletter. Okay, it is says it is printed information of IV dose metronidazole and oral dose metronidazole pharmacokinetics. Everybody know what is pharmacokinetics? Okay. So why it needs to be compared, oral versus IV? Why we should compare? If you go to a gynae ward, if you go to a obstetric maternity clinic, and if you ask the question to a clinician, doctor, which formulation you prefer, oral or IV? What doctor will say? I will prefer IV medication because it will act fast. Isn't it? Isn't it? है ना? तो डॉक्टर को ये ग्राफ दिखाना, ओके, डॉक्टर को दिखाना, गायनेकोलॉजिस्ट को दिखाना कि how oral pharmacokinetics of metronidazole is better or comparable to a IV metronidazole. Able to follow me, guys? Okay, so oral metronidazole is a cheaper, is a easy option for patient without any prick, without any injection related infections. Okay, so it is much comfortable for the patient as well as doctor. So such a information is routinely given by a drug information center in US, in developed nations. We can also try. We can also try in Jagdalpur. We can also try there in Chhattisgarh, right? Nearby hospital. You can create own newsletter. Then everybody should have a basic hands-on idea about how to search a question related answer here in the PubMed. You can see here there is option clinical queries. Okay, so you can type your questions in the clinical queries. Okay, and like uh, like a doctor asked me, can autism spectrum disorder patient can have a keto diet? क्या मैं इस पेशेंट को कीटो डाइट लिख सकती हूं? ऐसे मुझे डॉक्टर ने पूछा। तो मेरा जवाब क्या होना चाहिए? एवरीबडी कंफर्टेबल विद हिंदी? ओके, सो डॉक्टर ने ऑटिज्म का पेशेंट देखा, डॉक्टर ने कहीं पढ़ा था कि कीटो डाइट अच्छा होता है ऑटिज्म में। तो उन्होंने मुझसे सवाल किया कि क्या मैं पेशेंट को कीटो डाइट लिख सकती हूं? मैंने बोला कुछ समय दीजिए मैडम, मैं आपको जवाब बताता हूं। So I put that query in the PubMed. Okay, I selected therapy option, therapy, not the diagnosis, not the etiology or prognosis. And then look here what I got. I got 5 studies. I got 5 studies which have already experimented keto diet in autism spectrum disorder. Isn't it much better or time saving to look at just a 5 studies out of 21? So it is a good tool. Okay, the PubMed queries, it is a good tool where you can put your queries and you can get immediate answers. Otherwise, if you put a normal query in the PubMed, you will get a 71 article to read. Is it possible to read 71 article in a day? No. No. So it is better you can go for 5 articles. Then I used some of the filter like clinical trial, randomized control trial, and it gave me much filtered data in the PubMed. That is a randomized control trial data, which is a superior data. Okay, a controlled environment testing ketogenic diet in autism spectrum disorder. So you can give answer in 5 minutes. Okay, ma'am, you can go ahead with the keto diet in autism spectrum disorder patient. Okay, there is no harm. So you can also know that RCT, randomized control trial, are one of the best type of evidence. This is a evidence based medicine pyramid. Okay, it is a pyramid from down to upwards. The evidence or the strength of evidence increases. Randomized control trial and systematic review meta-analysis. Okay, if you look at some textbooks like Goodman Gilman, they are considered to be superior. Okay, when I read a textbooks, they said sulfonylurea पता है आपको, डायबिटीज की दवाई है. Everybody know sulfonylurea? ओके, सो सल्फोनिलयूरिया इस टेक्स्ट बुक के आधार पे ये कहता है इट ब्लॉक द इनवर्ड पोटेशियम करंट. ओके, मैंने मान लिया भाई अच्छी किताब है, अच्छा ही बोला होगा. सल्फोनिलयूरिया ब्लॉक इनवर्ड पोटेशियम करंट. ओके, मैंने मान लिया. ये है हैरिसन किताब. ओके, हैरिसन प्रिंसिपल ऑफ इंटरनल मेडिसिन, जो डॉक्टर लोग फॉलो करते हैं. This textbook says sulfonylurea block outward potassium current. The information is totally opposite. The information is totally opposite. Pharmacology book say inward, medicine book say outward. Okay, so here comes the role of pharmacy professionals. Okay, whenever you read with the strong intention to find the best possible answers. Okay, so information can be wrong. Okay, there are some researcher groups. They are routinely scrutinizing this sort of data, and they are coming up with the best answers. So best answers can be found in the Cochrane database. Okay, विटामिन ई प्रेगनेंसी में देना है या नहीं देना. ओके, कोविड का इंजेक्शन अभी लगाना है कि नहीं लगाना है. कोविड तो चला गया, फिर उसका इंजेक्शन लगाए या नहीं लगाए. ऐसे सवालों के जवाब यहाँ पे है. ठीक है. Other than Cochrane, there are other groups which are routinely publishing their scrutinized drug information. You can circulate this ready-made information to nearby doctors, and they will be happy to know that somebody is looking into a drug literature and giving the best information. Okay, so this is a third group, medical letters. They are also catering a best possible evidence on the drug. Okay, coming to Indian setting, I said snake bite, tuberculosis, malaria, dengue problem are not there. In
Coming
US,
to Indian
UK.
setting, I said.
Hello. Okay, so the disease pattern is different in India. Disease pattern is different in the developed countries. Okay, so can we follow all the information given by the Western researchers? No, we have to create our own team which can look at the Indian journals, Indian data, Indian diseases. Okay, Indian information. Okay, so there has to be a group. So let us have one exercise. Okay, everybody ready for an exercise? Okay, so we will have one question. Okay, and we will assess that question on these points. What is a problem question? Which are the patient population? What intervention they are going to try? Where to compare? Okay, which should be a comparator? How to analyze the outcome? How to comment upon the number of patients? How to comment upon the statistics? So a dermatologist called me. Okay, dermatologist called me saying that for my wart patient, common wart, everybody know wart. Okay, so wart patient, okay, cryotherapy is generally given. Cryotherapy, okay, ice therapy is generally given. The dermatologist has heard about duct tape therapy. Okay, सेलोटेप पता है आप सबको? हेलो, तो डर्मेटोलॉजिस्ट ने सुना था कि सेलोटेप भी लगा सकते हैं वायरल वार्ड्स पे. वायरल वार्ड्स एवरीबडी नो? ये एक तरह का स्किन डिसीज है जहां पे लीजन बन जाते हैं फिंगर टिप्स के ऊपर। ओके, तो ही वांटेड टू नो इफ you can recommend the new therapy, that is a duct tape therapy over cryotherapy। तो इसका जवाब क्या होगा? तो मैंने फिर से दोबारा पबमेड सर्च स्टार्ट किया। पेशेंट कौन है, किस पेशेंट को देना है, कौन सी थेरेपी देनी है, कैसे हम लोग इसकी एफिकेसी पे कमेंट कर पाएंगे, राइट? इस तरह से मैंने क्वेश्चन लिख लिया। मेरा क्वेश्चन था कि डक्ट टेप थेरेपी वार्ड्स के लिए बच्चों में सही है क्या नहीं है। आप अप टू डेट भी देख सकते हो, अप टू डेट वेबसाइट है जहां पे एविडेंस रेडीमेड मिलता है। जरूरी नहीं है कि इंडियन क्वेश्चन इंडियन टेक्स्ट में, इंडियन कंटेक्स्ट में बोला जाए। ओके, सो पबमेड का सहारा लिया मैंने। ओके, ये आर्टिकल मिला मुझे पहली बार। ओके, पहला ही आर्टिकल मैंने देखना शुरू किया, डक्ट टेप थेरेपी वर्सेस क्रायोथेरेपी। एक ट्रायल हुआ था मिलिट्री अस्पताल में जहां पे बच्चे यंग लोगों को एनरोल किया गया था, 61 पेशेंट्स, और आउटकम मेजर था कंप्लीट रिजोल्यूशन ऑफ द स्किन लीजन कंप्लीट रिजोल्यूशन देखा गया था। स्टडी ने बोला कि 85% रिस्पॉन्स आया डक्ट टेप थेरेपी के साथ में, 60% रिस्पॉन्स आया क्रायोथेरेपी के साथ में। तो डक्ट टेप थेरेपी अच्छी है। क्या हम लोग ये आंसर डॉक्टर को बता सकते हैं? कैन वी से that you should try duct tape therapy based upon this finding? Yes or no? Okay, so I also had a little bit of skeptical mind, okay, before I convey my answer. So what I began looking at, is the clinical condition really the same to determine application of duct tape therapy as effective as cryotherapy in treatment of common warts? Okay, so I also had a little bit of skeptical mind, okay, before I convey my answer. So what I began looking at is, okay, so the problem should be sufficiently similar to your clinical question, isn't it? Okay, the problem question should be similar to clinical question. Is the study group similar to your practice, your patients? This study happened in military medical center. Okay, can a military medical center finding be generalized? Can military medical center findings be generalized? इनके फाइंडिंग सारे पेशेंट्स को जनरलाइज कर सकते हैं क्या? कम ऑन प्लीज स्पीक अप। मिलिट्री मेडिकल सेंटर में ये टेस्टिंग हुआ था, इनके फाइंडिंग्स हम अपने पेशेंट को रेकमेंड कर सकते हैं क्या? So military medical center generally get a patient with a particular exposure. They are not like a general patient pool. Okay, they have different exposures. Okay, no doubt the age group was relevant for us. Okay,
Sir, can you change the slide, sir?
sorry,
Sir, please change the slide.
I'm not able to hear you. Somebody trying to say something?
Yes, sir. Slides, please change the slides. Slides are not moving.
Okay, which slide you are able to see?
Only first slide, sir.
Sorry,
Only first slide is visible, sir.
which slide you are seeing?
Yes, sir. Now we have got the slide. Program PPI icons we will got it.
Is it moving now?
Yes, sir.
Shall I continue?
Yes, sir. Please continue.
Okay. So we were looking at population. Is the study group similar to your patient or the the similar to question that has been raised by dermatologist. So I was talking about military medical center where the patient may have certain different exposures, which may not be uh, routinely encountered in a general practice. Okay, but age group is same in this PubMed article, so we can still look into this article. If the patient in the study are not similar to your patient, like if the PubMed article is saying older, sicker, different gender, more clinically complicated patients in the article, the result may not be relevant. Okay, so you have to be very, very meticulous while selecting a PubMed article while answering the question. When you look at the intervention, is the intervention same what you were actually looking for, or it is a diagnostic testing that is done in the PubMed article? Okay, so the dermatologist has heard about treating warts with the duct tape therapy, want to know if you can recommend this treatment. Comparison, okay, against what this treatment is being compared. Okay, could it be a diagnostic or another therapy or a placebo comparison or no comparison? Okay. So in the PubMed article, which we are referring to, the patient were randomized using computer generated codes to receive either cryotherapy for a maximum period of 6 treatments or a duct tape occlusion therapy for maximum period of 2 months. Is it okay comparison wise? What is your say? What is your say on this? Is the comparison okay? So you can, whatever time the duct tape therapy is tried here, those many sessions you can recommend to a dermatologist. Okay. Right now there is a idea of not looking at the lab test. Okay, alone. Disease oriented outcomes we call it. Change in the complete blood cell count, change in the platelet count, change in the hemoglobin count. Okay, some doctors they only look at the lab reports. Okay, x-ray clean है घर भेज दो. Okay, blood test clean है घर भेज दो. Blood culture sterile है घर भेज दो. Okay, so that might be a approach by certain doctors. Okay, it has been long assumed that improving the physiological parameter like hemoglobin, complete blood count, total leukocyte count, okay, total cholesterol will result in a better outcome. Okay, but this is not always true. Patient oriented evidence that matters most. Okay, so whether the quality of life of patient is better or not, whether the patient is pain free or not, whether the patient is comfortable cost wise or not, whether the patient is not carrying long term mortality or morbidity risk or not, all these things has to be looked into when you look at any article or any evidence in the PubMed. Okay, so therefore the disease oriented outcomes are interesting, okay, but questionable relevance, whereas the patient oriented outcomes are very interesting and very relevant. Okay, you should be looking at patient oriented outcomes. So complete resolution of what was studied there. What is your opinion? Is it a patient oriented outcome or a disease oriented outcome? Complete resolution of what? So you need to have some basic understanding of the disease. Wart is a disfigurement, a cosmetic problem. Okay. If there is a lesion on the fingertip, if there is a skin lesion on the fingertip, okay, it may not be comfortable for a girl. It may not be a comfortable for even boys. Okay. Carrying a lesion on a finger in a meeting or school or any place. Right. So it is a good outcome according to me. Okay. Then number of subjects studied in the article. Too few patients may not be enough to show the difference that really exists between intervention and comparison. So power of study needs to be checked. Okay. Many studies, okay, they have a less number of patients. Okay, when you look into PubMed, so they may not be statistically strong, evidence based. When the sample size is more than 400 or something like that, larger sample size, it is mostly a genuine findings. Okay. So the study had completed 61 patients. Sorry for the typographical mistake. Okay. Then there is a, then there is a, you can say, a refined statistics you can apply. Okay. The study had shown a difference of 85% and 60%. Am I right? Okay. The difference in the two arms, duct tape therapy and cryotherapy, 85% and 60%, right? Okay. So can you find out relative risk reduction? That is a percent reduction in the event in the treated group compared to control group. It is not a good way of comparison. Okay, it amplifies the small difference. Doesn't reflect the baseline risk of the outcome event. It can make the weak result look good. Therefore, it may be popular, but it is not a good idea to report. So ignore. It can mislead you. If you calculate relative risk reduction, it is not a RRR movie of uh, the Indian movie that bagged Oscar for the music. It is a relative risk reduction. Okay, 85% minus 60% divided by 60%. Okay, the 25% difference is amplified to 42%. Everybody is able to follow me, guys. Everybody is able to follow me, guys. Or is it a postprandial session making you sleepy? So the statistics can change your finding. Statistics can change your finding. The 25% difference, what was reported by the study, may be amplified by certain other statistical methods. Okay. So never look at such articles which are amplifying the difference. Then there is absolute risk reduction. This is a just a subtraction. Okay, it is giving you a direct benefit of directly observed difference. 85 minus 60, that is 25% difference or 25% better duct tape therapy. Okay, a better statistics that show the true difference. Okay, then there is another way of presenting the statistics or finding number needed to treat. Number needed to treat so that one patient benefits. Number needed to treat so that one patient benefits. Okay. How you can calculate? Just take a inverse of absolute reduction risk. Just take a inverse of absolute reduction risk. Okay. So 1 upon 25 is 4%. Okay, 4%. So 4 patient needs to be treated with duct tape therapy for one to get benefit. 4 patient needs to be treated with duct tape therapy for one to benefit. Okay, now you can be in a better position to take a clinical decision. Okay, tell me now, do you recommend the duct tape therapy over cryotherapy? Do you recommend? Please interact, guys. I do not feel comfortable with one way communication. अगर आपको 4 पेशेंट को नई दवाई देनी पड़ी और उसमें से सिर्फ एक पेशेंट को फायदा होने वाला है, क्या आप नई दवाई दोगे?
No, sir.
एग्जैक्टली. ओके. सो अगर 4 में से सिर्फ एक पेशेंट को फायदा होगा तो नई दवाई नहीं देंगे. So it is a way of looking at the PubMed literature what I have presented here. Okay. So what is our answer to a dermatologist? Please don't give this new therapy. Okay. There are other case scenarios of worst case scenario. Okay, which I will not go into a detail, but that can take the finding in the opposite direction also. स्टैटिस्टिकली सिग्निफिकेंट रिजल्ट्स को नॉन सिग्निफिकेंट कर सकता है. ओके, बट remember you have to be meticulous when you look at the PubMed data. Okay, so we started answering clinical questions in 2015. We collected the basic information: date of query, time of query, name of the doctor, name of the department, कितना urgently answer चाहिए, ओके, ईमेल पे, व्हाट्सएप पे, मोबाइल पे आंसर चाहिए, ओके, पेशेंट का थोड़ा बहुत डेटा ले लिया, ओके, कौन सा पेशेंट है, कहाँ पे एडमिट है, इमरजेंसी में है क्या, जेनेरिक दवाई ले रहा है क्या, ओके, देन हमारे जवाब से डॉक्टर खुश है क्या. This is also important. Okay, when you build some services like a drug information services, where whether your doctors are happy with your service or not. Okay, so we jotted down this information and we build our services. Okay, then we thought, let us educate our colleagues also. Okay, there are pharmacology, pharmacy colleagues. You are my colleague. Okay, you are my colleague. Okay, maybe after few years. Okay, but you are my colleague from today itself. Okay, so when I say I want to educate my colleagues, I simply circulated a knowledge attitude practice questionnaire. Okay, an online survey I did via email, Facebook, and WhatsApp. And I look at the information where my friends, where my colleagues are finding problems. Okay, so my fellow colleagues are finding problems in critically appraisal of published literature, which example I gave you. Okay, and they need to be guided on how to establish and maintain the services. Okay, so PubMed guidance or PubMed literature analysis can be a 7-day workshop. I will be happy to help you out if you require any more lectures from my side. Okay, so we collected opinions of faculties like, can effective drug information center control irrational use of medicines. इरेशनल यूज ऑफ मेडिसिन को कंट्रोल किया जा सकता है क्या इन सर्विसेज से. तो सब लोगों ने हाँ बोला. सब लोगों ने कहा कि इरेशनल मेडिसिन यूज कम हो सकता है. ओके, देन कैन ड्रग इंफॉर्मेशन सेंटर रिड्यूस द हेल्थ केयर कॉस्ट. क्या पेशेंट के ऊपर पैसों का खर्च कम किया जा सकता है क्या. क्या पेशेंट की मॉर्बिडिटी कम हो सकती है क्या, मॉर्टेलिटी कम हो सकती है क्या. सब लोगों ने हाँ बोला. ओके, what is the important purpose of drug information center? Providing unbiased drug information, train postgraduates, graduates, control irrational drug use. Everybody accepted that. Okay, so how to generate the funds, how to start the services was the big question for the fellow colleagues. So everybody said no for that. Okay, everybody say we require setup, we require this, we require that. Okay, so any guidance beyond my capacity or your capacity, okay, please let me know if you require any guidance on how to establish and run the services. Then I thought, let us take my fellow pharmacy colleagues together. Okay, pharmacologist I earlier interviewed. Now I combined pharmacy and pharmacology, both the faculties. Okay, then I found what the pharmacy, the low knowledge score and low practice scores, okay, require again training in critical appraisal of published literature. Okay, so collaborative approach can be a benefited between pharmacist and pharmacologist. Okay, अगर हम आपस में मिलके काम करें, ओके, तो बहुत ही अच्छे से डॉक्टर्स को गाइड किया जा सकता है. ओके, सो ये था. देन हम लोगों ने अमेरिका में, यूके में कैसे मेडिसिन इंफॉर्मेशन सर्विसेज चलती है उनके साथ भी कंपेयर करके देखा. उनसे हम लोग क्या सीख सकते हैं वो हमने नोट किया. देन हम लोगों ने हमारा खुद का फेसबुक पेज चलाया. हमने हमारे फेसबुक पेज पे रोज एक क्वेश्चन आंसर करना शुरू कर दिया जिसका जवाब वहां पे लिखा था रेफरेंसेस के साथ में। आप सब ये देख पा रहे हैं? फेसबुक फेसबुक ओके ओके, फेसबुक सारे लोग इस्तेमाल करते हो? अच्छा, तो ट्विटर इस्तेमाल करते हो? ओके, so whatever social media platform you are comfortable with, okay, you can start utilizing it as a medium for educating fellow colleagues, fellow doctors. So I started posting one clinical question, one best answer, and a few of the best references from the PubMed, and sometimes the evidence level also. Okay. The doctor started looking at my Facebook page. Doctors started taking the help from these answers, and their patient outcome improved. Can you imagine? The patients and doctors are benefiting from Facebook page, okay, while relaxing in chair, okay, while it is a midnight, while it is a early morning, when you immediately get up and open your phone, okay, you have the best answer for the critical question. Okay, so likely we assessed our Facebook page reachability. Okay, we were able to cater Pakistani doctors, we were able to help Bangladesh doctors, Sri Lanka doctors, Nepal doctors, we were able to help African doctors. Okay, so many people benefited out of our Facebook page education podium, okay, services. Then we started a WhatsApp group for patient education. You are able to see this? Okay, this is a WhatsApp page. Okay, so this is a WhatsApp group of patient. Okay, so a patient says, "Thank you, Dr. Saab, for your kind cooperation." Okay,
Sir, may I interrupt, sir? Your
yes.
slide is stuck, sir. We cannot see.
Which slide you are stuck, sir?
Problem PP icons in this slide we are stuck. In the 31 slide number. Yes, sir. Now it is visible.
Now it is visible.
Yes, sir.
It is moving.
No, sir. Not moving.
Is it moving?
No, sir.
Uh, is it visible?
Yes, sir. Visible.
Uh, I I I ran much faster, I guess.
Yes, sir.
So, do you want me to start from this slide again?
Yes, sir. You can continue, sir.
So, number needed to treat is one of the better method to look at any statistical information that is presented in the PubMed literature. It gives you a best possible answer. Okay, we if you remember, we have this study from the PubMed showing 85% and 60% difference in ductape therapy and cryotherapy. Okay, so difference 25% difference is the sample size I recommended. Only 61 patient had been mentioned in the article. More the patient, better is a finding. More the patient, better is a finding. Better you can rely on the study findings. Then relative risk reduction statistics can amplify the small differences. Please ignore such information if you come across in the PubMed literature. Okay, it can amplify the small difference. It can amplify the 25% difference to 42%. Okay, so it can mislead you. It can mislead the doctors. Absolute risk reduction gives you a true difference. So 85 minus 60, 25%, a true difference. that you can communicate to a doctor. Okay. Number needed to treat is the inverse. It is an inverse of absolute risk reduction. Okay. 4 patients are need to be treated with ductape therapy for 1 to benefit. So based upon this finding, you will never recommend ductape therapy, right, for a dermatologist, and you can give them evidence of this study. Okay. So that is how you have to look at the PubMed literature meticulously. There are sophisticated statistics which I will not go into the detail. Okay. But statistics play an important part when you look at any literature in the PubMed. This is a data collection form which we circulated in the doctors while answering their queries. Okay. Then this is a study, small study we did to find out what a fellow pharmacology colleagues. Hello, able to see the slide? Able to see the slide decoding the roadmap?
Sir, we can only see statistics PP icon.
Uh,
Sir, if you can, you will zoom, sir, then I think.
this one?
No, sir. You just double click. In the lower right hand corner side, sir, one option is there.
Okay now?
Yes, sir. Statistics PP icons. That slide is visible.
Okay. So could you understand the concept of number needed to treat?
Yes, sir.
Okay. So I'll not maximize the slide. I think there is a problem. Now the slide is moving correctly.
No, sir. That is stuck.
Intention to treat analysis.
Yes, yes.
Yes, sir. Yes. Now it is.
Okay. So intention to treat analysis. There are many ways you can look at the literature. I will maximize this. Okay. So there are many sophisticated ways to look at a particular literature in the PubMed, and you have to be really careful. Then this is a data collection form. We collected information from fellow colleagues for the answers provided to clinician doctors. Okay. A drug information center, the question, the answer, the time and date of the queries. Okay. Then fellow colleagues like a pharmacologist, they need to be trained in which way for capacity building so that they are able to cater a drug information center services in India. So we found that they need to be trained in critical appraisal of published literature. Okay. How to look at a particular study, how to interpret their findings. That kind of guidance was missing. Okay. So we are educating via various sessions or conferences or the workshop. Okay. So I can also have a different session or a different workshop with you guys. Okay. How to do a PubMed literature search. Okay. Then this is a small survey, same survey, which points they believe that the drug information center can do, and which support they needed. Like they needed much more support in establishment of a drug information center and maintaining their activities. Okay. So are ready to help you out anytime. Okay. Whenever you ask. Then I did another study with a pharmacy colleagues. Okay. Pharmacy and pharmacologist colleagues. Okay. They can be a collaborative approach, can be a very much useful for everyone or doctors to benefit. Okay. So pharmacy and pharmacologist colleagues, they should join hands in helping the doctors with catering the best possible medication information. Okay. We compared our services with the developed countries. Okay. You can look into that. Then we started posting our questions on Facebook page with the answer. You are able to see this slide, guys?
Yes, yes, yes. We
Okay.
can see.
So we posted a question on a Facebook page. You can also log in. Okay. You can also search Drug Information Center PGIMER. Okay. You can also see how we are putting up a question, how we are answering the question, how we are providing the references. You can similarly start your own. Okay. I want to see Chhattisgarh become a pioneer of this services. Okay, it is a simple, no funding is required, nothing is required, just a commitment is necessary. Okay, so you can start these services, you can build your Facebook page. Facebook page is costing nothing. Okay, so please look at the examples on the Facebook and start your own service so that the nearby doctors can benefit it. Okay, so our Facebook page was able to help doctors beyond border. Okay, doctors beyond borders, they are benefited, like Pakistan, Nepal, Sri Lanka, Bangladesh. They all got their answers on the Facebook page, and it was very much helpful out beyond the borders. Okay, so we saw our Facebook post reach, Facebook post likes, Facebook post shares. Okay, so we calculated and presented in a paper form, and that was appreciated by US Pharmacy Council. Okay, you know this journal, Journal of American Pharmacy Association. You know this journal, guys, JAFA. Okay, so the Pharmacy Association in America, they appreciated our efforts. Okay, then we started patient education WhatsApp group. Okay, I will read out the message for you. Okay, I provided a patient education for mastocytosis patient, a small baby. I guided their parent which drugs should be avoided in mastocytosis condition. It is a genetic condition where uh, alkaline drugs can be harmful, okay, which will destabilize mast cells and release histamine. Histamine release होगा तो क्या होगा बच्चों? Histamine हिस्टामिन रिलीज होगा तो क्या होगा? एलर्जी होगा, ब्लड प्रेशर फॉल होगा, ओके, हाइपोटेंशन हो सकता है, शॉक हो सकता है. So I just educated this parent of the child, and they said it is your great support to bring my daughter out of horrible situation to her normal life. Special thanks to PGI staff, great team with a sound knowledge. Good day. Okay, so one life was saved. One life was saved out of just a medicine information. Okay, so that's how you can build your own services. Lastly, I would like to pay tribute to my guide, my mentor, KK Sharma sir. Okay, you may have seen his textbook. Okay, KK Sharma sir. He is right now no more, but he is deeper in our hearts. Thank you very much.
Thank you very much, sir, for your
Thank you,
valuable
sir.
time.
Thank you very much.
I want to Dr. Mahendra Panikai sir to say the vote of thanks.
Sir,
Thank you, sir.
thank you very much. I am happy to answer any question if there is.
Any students, sir, please ask questions.
I will be happy to interact with the students. I love my students.
Sir, how can you establish the drug information center at our college?
I am not able to hear properly. Can you ask
Drug
again?
information center at our institution. What is the process, sir?
First of all, communication is important. Communication with doctors is important. Okay, I started collecting their phone numbers. I started building a sort of a directory, telephone directory. So likewise, I started building my doctor's directory in my hospital. I started them sending good day, good morning wishes. With that, I started sending them newsletters from Harvard, from Cochrane, from the best possible place. What is the best evidence on existing drug literature? Okay. Then I started getting up the questions. Okay. I started answering those questions, and that's how I builded a rapport with a clinician. Building a rapport with clinician is a very important thing. Okay, you saw my letterhead in the presentation, how I started communicating on my letterhead. I started communicating on WhatsApp, I started communicating on Facebook, I started communicating via SMS. Okay,
Yes, sir.
so communication is the key. Everybody has a laptop, everybody has a internet. Okay, you don't require anything above that. Okay.
Yes, sir. The students can they open the Facebook pages and they can communicate to the doctors or to whom they will communicate regarding the drugs adverse reaction.
uh, Sorry, is it a question for me, sir?
Yes, sir.
Sir, can you repeat question, sir, again?
Yes, sir. How the students can report if they will be come across any adverse drug reaction, to whom they will report, sir?
Adverse drug reaction.
Yes, to whom they will report if they will found that any tablet or capsule has been used by any of the patient and there is a skin rash and there is a skin rash is coming, then to whom they will report, sir?
Pharmacovigilance, sir, ADR monitoring centers are there.
Yes,
Uh, Adverse drug reaction can be reported to ADR monitoring centers.
yes, sir.
We go beyond that and we guide the clinician what is the alternative medicine if somebody has developed a hypersensitivity reaction or anaphylaxis or something.
Yes, sir.
So we go beyond pharmacovigilance and we help the clinician with the drug information.
Okay, okay, sir. Thank you, sir. Any questions from students?
Yes, sir.
Yes, any question from student side? Thank you, sir. You have given your valuable time to encourage and inspire to our students on the valuable topic evidence-based medicines and call services. A call for pharmacy and pharmacology professionals. Really, sir, our student has learned a lot of idea in regarding the drugs, its interactions, and also regarding the drugs, how to take care and to report to the doctors if they will have any difficulty or any adverse situations they will face it. Really, we are proud of you, sir, and thank you, sir, for your guidance to all of us, sir.
Thank you, sir. One small thing I would like to mention before I conclude. Uh, we, we live in the era. Thank you. Thank you. Sir, we live in the era where artificial intelligence is taking much more role,
Yes,
and many of the textbooks are written by Chat GPT. So, scrutinizing a medicine information becomes a very much necessity. Okay, so if you require further assistance of mine in how to look at the drug information, I will be happy to help you out, sir.
thank you. Please,
Thank you.
on behalf of our institution, please accept the moment to okay. Please, all of the students give a very good clap to Dr. Anmol, sir. sir.
Thank you very much.
You will get the opportunity. You will meet in future. Thank you.
Thank you. Shall I log out, sir? Sir, shall I log out or shall I stay, sir?
No, sir, it's, I think, over, sir. Thank you very much, sir.
Thank you, sir. Thank you very much, sir.